Which one should I see?
Oh, this is the same.
Good morning, it's a pleasure to be here and such a huge audience. My topic is a place of non-adrenergic agents. We just heard about the toxicity of adrenergic one, so I will try to explain why we could use perhaps other one. If you're looking at the ESA guidelines, the indications for inotropes are very restrictive, as you know. It should be in the presence of acute or chronic hemodynamic compromise with an organ dysfunction due to low output. And in the absence of that, catecholamine inotropes are considered toxic, detrimental, or contraindicated. However, if you're looking at most of the heart failure studies, large heart failure studies, they're using inotrope in 39 to 70%, and in population of cardiac surgery, they're also using it in 20 to 90%. So we're definitely not criminal, but I think these patients need something to help them. What are the indications for levetiracetam or PDA3 inhibitors in these guidelines? It's very restricted also. It may be considered to reverse the effect of beta blockade if beta blockade is so to be contributing to hypotension with subsequent hypoperfusion. Toxicity of adrenergic agents or for inotropes. There is this meta-analysis which has been recently published on almost 30,000 patients. It's a meta-analysis, of course. It's always the signification of that is always restricted. However, most of the paper were on levetiracetam, 13% on dopamine, and 10% of milrinone. The setting is cardiac surgery and heart failure mostly, and mostly also were placebo-controlled. And in these meta-analyses, the inotrope and vasopressors had no detrimental effect on survival. So we might still have changed with our substances. Looking at the PDA3 inhibitors like milrinone, how does it work? You know that it's independent from receptor beta. It will block the breakdown of CAMP by phosphodiesterases and increase intracellular CAMP and intracellular calcium. It has been shown to have a positive inotropic effect, to decrease preload and afterload, to remain active in case of beta blockade as far as it's not working on the beta receptors. His half-life is 2.5 hours. And it has several secondary effects, such as arrhythmias, hypotension, angina, and headache. One of the other problems is a CAMP-dependent substance. Is it a problem in heart failure patients? Yes. Why? Because in heart failure patients, you have a downregulation of beta receptor, and you have also a decrease in concentration of CAMP. So you're using a substance which is working on a substrate which is already decreased. On top of that, CAMP-dependent or calcium mobilizers has been done to increase oxygen consumption, first through the reinternalization of calcium during diastole and through the positive chronotropic effect. It has been shown to develop tachyphylaxis, to cause ventricular arrhythmia, and to accelerate myocardial remodeling and apoptosis, and to possibly impair diastolic function. The oxygen consumption, although at the beginning when we were starting to use milrinone, we thought also that the substance was less toxic in terms of oxygen consumption. It's definitely consuming more oxygen than levetiracetam. There is very few good studies on PDE3 inhibitors. There is in the context of heart failure. There is a very old meta-analysis on oral phosphodiesterases, which showed an increased mortality, but none of these inotropes is currently in use. We don't have PDE3, oral PDE3 nowadays. And the online CHF study on IV Renon compared with placebo in almost 1,000 patients. They excluded the unstable patient, which is a little bit strange because the unstable patients are the ones who are needing catecholamine. However, they had no significant difference in the hospital and 2 months mortality, but more episode of hypotension and arrhythmias. And in post-hoc analysis, they had a higher mortality with ischemic cardiomyopathy. So actually, if you're looking at the literature, there is no large randomized controlled trial evaluating long-term, continuous, or repetitive IV administration of PDE3 inhibitors. The use of inotrope on top of that is by treating physician is generally very highly heterogeneous, so very difficult to compare. There is few data on central hemodynamic, and some study excluded the low cardiac output syndrome. And most trials are also performed before the era of ECD, meaning patients dying from arrhythmias might be eliminated through the ICD. Now, the levosimendan is a completely different mechanism of action. It's a calcium sensitizer. It stabilizes the complex troponin C and calcium and increase the duration of actin and myosin compound. It will extend in this way and amplify the contraction, the myocardial contraction. Through the opening of ATP-sensitive kalium channels on the smooth muscle, it will create vasodilatation, and at the level of the mitochondria, it might also produce preconditioning. It has been shown because it's a CMP-independent inotrope, it probably doesn't cause arrhythmias, although there is new experimental paper just coming out showing that it's also a pro-arrhythmogenic substance, and we can see it also a little bit clinically, I must say. It doesn't increase oxygen consumption. It has no negative lusitropic effect, possibly positive lusitropic effect. It has a short half-life for his initial compound, but has active metabolites which have a long half-life, 75 to 80 hours, with effect lasting up to 7 to 9 days, which might be a very good advantage for heart failure patients. It has no sign of development of tolerance, and it has also some secondary effects such as hypotension, arrhythmias, hypokalemia, and tachycardia. It has been shown to be neutral or beneficial in terms of cardiac energy demand, in terms of neurohormonal activation, renal function, and interaction with beta blockade. And it is actually the only inotropic agent that might reduce mortality in critically ill patients, but we're still needing a randomized study, a large randomized study to prove it. They're coming out nowadays. And it has been also included among 8 anti-arrhythmic drugs, techniques, or strategies that might decrease mortality in cardiac surgery. This meta-analysis published for 2 years showed in a population of, in a cardiological population as well as in a cardiosurgical population that levosimendan had a very favorable effect on renal function. It decreased the incidence of renal replacement therapy and the incidence of acute kidney insufficiency. It has been shown also to decrease mortality in a cardiological as well as cardiosurgical population, and to decrease the length of stay in the ICU in a cardiological population. Actually, there is more than 25 meta-analyses which has been published in the last 20 years from 16 international research groups on more than 6,000 patients. 10 of those in cardiac surgery population, 5 of those in acute heart failure population, 13 describe a positive effect on mortality, 2 on renal function. So that's the actual evidence is actually in favor of usefulness and efficacy of levosimendan, but we have to be careful. It's mostly small series of patients, small studies. Levosimendan ameliorates the symptoms of acute heart failure. It improves hemodynamic without attenuation in the case of beta blockade. It has decreased BNP, TNF-alpha, and interleukin through an anti-inflammatory effect and preconditioning effect. Improves quality of life and reduces mortality with improvement of renal function, as I said already before. The Lionheart study has been hasn't been published yet, but has been the preliminary result has been presented in the Heart Failure Congress in Seville in 2015. 69 patients randomized 2-to-1 for levosimendan or placebo. There was a significant reduction in NT-proBNP, clinical improvement under levosimendan with a reduction of the risk of hospitalization or death, and lesser decline in quality of life over time. So the conclusion was that the intermittent administration of levosimendan is safe and well tolerated. And the LEVEL-REP study is also a large randomized study on 120 patients with advanced heart failure. Levosimendan was repetitively used over 6 hours every 2 weeks and over 6 weeks, control at 24 weeks. The secondary, there was no difference in the primary outcome, but the secondary outcome was positive for the levosimendan group of patients, with a decrease in deaths in emergent transplantation and acute heart failure decompensation. These new meta-analyses on repeated or intermittent levosimendan in advanced heart failure is also positive in terms of mortality for the patient treated by levosimendan. And some indication have been published in this expert opinion paper from Niemans and colleagues. Indication for repetitive use of levosimendan might be severe systolic dysfunction with an EF less than 35%, by a patient with a NYHA 3B to 4 or Intermax levels 4 to 6, suffering repeated hospitalization or emergency department visits more than 2 in the past year, and all the above despite optimal treatment of heart failure. The dosing is still not quite clear, between 0.05 to 0.2 microgram per kilo per minute for 6 to 24 hours every 2 weeks to 4 weeks. It's still relatively vague. What's definitely important is to avoid hypovolemia by this patient, to avoid hypotension, and to avoid low serum electrolyte values, to avoid arrhythmias. The goals of intermittent levosimendan has also to be defined. They are not the same in patients which are bridged to transplantation or left ventricular assist device implantation, or if they are in a palliative therapy. In bridge to transplantation, they are levosimendan is used to maintain and preserve organ function, to optimize the patient in the direction of their procedures and maximize their chance of recovery, and to reduce the risk of death or for emergent cardiac transplantation. As palliative therapy, however, the impact on the mortality is probably less important. What is more important is the optimization of the quality of life, maximizing physical function and reducing the risk of hospitalization. In conclusion, there is no large control trial on intravenous and intermittent use of melurinon. Those on levosimendan are emerging. Levosimendan is actually the only inotropic agent that might increase survival by critically ill patients. However, there is no universal inotrope. and drugs targeted to focused patient groups are highly needed on cardiogenic shock, acute heart failure with low ejection fraction, low cardiac output after cardiac surgery, or septic shock and cardiac depression. I thank you for your attention.